Dr. Pratik, everybody know he doesn't need any introduction. He's very, very academician. He's more into academic. I don't know, does he sleep or not? Every week he is with a new webinar with a very good take-home message for the doctors to update and also for the public interest. And this PCOS again is very, very useful for the public interest. So Dr. Pradeep recently elected as a body, governing council member, and he is also in the Maharashtra Council. He is being the chairperson of the Foxy chair. And Dr. Barsa, I would like, please you read. I am not able to see. I
Yeah.
don't
I
know.
think
So
that's enough.
It's not
That's
coming.
enough.
let me introduce Dr.
No,
Pratik
it's not
Tambe.
coming.
It is my, I'm really delighted to introduce Dr. Pratik Tambe. He is a ART consultant, gynae endoscopic surgeon from Ashirwad IVF Mumbai, international diploma holder in advanced laparoscopy surgery from France, trained in assisted ART in Belgium, trained in clinical embryology at London and Singapore, chairperson of AMOG's endocrinological committee. He has really done wonderful work during 2020 to 24 and governing council member newly elected. Congratulations, Dr. Pratik, for that. Veteran and managing council member, and he has also been elected with maximum number of votes. And he's a managing committee member, Indian Society of ISAR, managing committee, Maharashtra chapter ISAR, managing committee member, Maharashtra chapter ISAR, again recipient of 30 emojis among ISAR Foxy prizes and award. Editor of 24 books, 4 Foxy focuses and books, and 11 key practice contributed more than 100 chapters. Pratik Tambe, you are welcome, and he has received so many awards and whatnot. मेरा तो webinar ही हो गया. So now he is going to talk on new horizons in PCOS management. So over to you, Dr. Pratik Tambe. We are eager to listen to you.
Thank you very
One
much.
thing more,
Before
Dr.
you start,
Barsha, thank
Pratik,
you so much,
Pratik,
Dr. Barsha. One thing more, he is a very, very humble person and friend of the France.
Pratik, one second.
Thank you so much,
That machine is
Tarini.
called
And
BiPAP machine for
Yes,
for sleep apnea.
absolutely. Absolutely. Yes.
अरे आप सब लोग
I
इतने
couldn't
अच्छे हैं,
remember the
तो you
name.
made me humble also. Thank you so much.
So thank you very much, dear friends, for being here with us today. And I'm going to try and focus on the newer horizons, the new guidelines, and the new evidence that we have when we talk about PCOS management. I'm going to assume that my screen is visible and I'm audible, and I'm going to go ahead. When we first
Pratik, it is
started these,
visible. Only talk little louder.
when we first started these TOG experience series and the series of webinars with different scientific backgrounds and different topics in the pandemic, we had absolutely no idea that it was going to become such a super duper hit. In fact, we regularly have more than 1,500 viewers, even though it's in the afternoon. It's something which we do on a weekday when there are a lot of people who are already at work. And even today, we have over 800 viewers who are visible and they are live logged in. So when I'm asked, why did we actually start all this? Usually like to go back to this beautiful quote from Aristotle, which is more than 500 years old, and where he said that education is an ornament in prosperity, it's a refuge in adversity. It basically started because we wanted to see our friends while we were locked up in our homes or in our clinics during the pandemic. We were all isolated and we wanted to feel normal. We wanted to establish some amount of normalcy during the difficult period of the pandemic. And that's how we started this entire journey. It's continuing. I hope more and more of you will join us over a period of time. You will get informed regarding practical recent advances which you can implement in your own clinical practice, and hopefully your patients will also be benefited as a result of these educational events that we do, thanks to the efforts of our academic partners and also Science Integra, who are our scientific backbone for all these events. If you look at recent papers, this is one of them, which is published in Human Reproduction, and this is probably the largest ever collation of evidence from 194 countries, which looks at polycystic ovary syndrome, how the trends have changed, how the global disease burden is now different compared to what it was 20 years ago. They begin by saying that about 1.5 million new cases are being reported globally. And of course, this is from 2017. I'm pretty sure that this data is relatively older. Many more new cases are being reported. Again, the onus of reporting is not on us in countries like India. It's not something which is required by law or it's mandatory. For example, if you have somebody with malaria or typhoid, that's a notifiable disease that needs to be reported. PCOS is not a notifiable disease. Therefore, I'm pretty sure that this data is not accurate. Be that as it may, I'll just go ahead and show you how things have changed as compared to 15 or 20 years ago. There is an increase of 4.5% from 2007 to 2017. The global age standardized incidence of PCOS is now as high as 82 per 100,000 population. This represents an increase of 1.5% in just 10 years from 2007 to 2017. So you can see that the numbers are increasing significantly over a period of time. And even in countries like India, these numbers are shooting up in astronomical proportions. This is the most recent ESHRE guideline, which was published last month. It's freely available on the ESHRE website. It's public domain. You don't have to pay for it. You can download it. If you can't find it, please feel free to send me an email. I'll be happy to share it with you. And if you find that the 200 plus pages of the guideline are very boring, laborious, and tedious to read, which it is, unless you're an academician, then you can go to these synopses, and this is a lovely paper by Helena T. et al., who are actually the workers behind that exhaustive guideline. And they've summarized the most important recommendations in this paper. Again, this is something which is freely and easily available. If you can't find it, then email me, I'll send it. Many of these recommendations have already been covered by Dr. Jyoti Bali in her talk, and therefore I'm going to skim past the parts which are repetitions, and I'll try and focus more on clinical practice guidelines and other newer evidence because this is already being covered, and I don't want to make it tedious and boring for the audience. The one big difference in the ultrasound criteria as per the new guideline published last month is that besides follicle number per ovary or FNPO, which is used in antral follicle counts, there is also a new criterion called as follicle number per cross section of the ovary, also called as FNPS. And this is a new marker which is supposed to be more diagnostic and more accurate for women in the diagnosis of PCOS. Again, the old criteria of ovarian volume continues. And again, as Jyoti mentioned, in adolescents, follicle numbers for ovary are not possible to do because we can't do a transvaginal scan in Indian patients who are adolescents. So these criteria are only for adults. Again, you need to have a standardized 8 megahertz probe, which is used. Transabdominal sonography is not to be utilized. The clinical presentations are well known to all of us, and most commonly patients will present to you with one or combinations of these issues. One of the major issues which are now cropping up in 2023 are mental health issues, which briefly Jyoti has touched upon, and we will talk about a little later. So how do you diagnose your hyperandrogenism? The first and most important thing to remember is that not all androgen excess is equal to PCOS. It's very easy to overdiagnose PCOS. It's very easy to forget that there are other conditions as well, which can mimic androgen excess, notably ovarian tumors, etc. And that has been covered in the previous talk as well. So as far as the clinical assessment is concerned, you need to have your Perriman-Galway score, which is there in place. For male pattern baldness or alopecia, you have something called as a Ludwig score, and you need to have a modified Perriman-Galway score of 4 to 6 to detect hirsutism. This was actually devised way back in the 60s, and I don't know many of us who use it in clinical practice, but this is an excellent tool, especially to judge a response to anti-androgen therapy because it's a long-term treatment, takes 6 to 12 months, bare minimum, to show any improvement and visible benefit for most patients. As far as the biochemical assessments are concerned, the tests that are recommended are the newer LCMS assays, which are liquid chromatography and mass spectrometry. These, of course, are not widely available. Where they are available, they are extremely expensive, and most parts of India, we still use the older ELISA tests, which are not very accurate. With that being said, should we actually do these tests in the first place? Or are we just adding to the burden, the cost burden to our patients? They are actually not something which are recommended widely, but I feel that they should be done at least once to ensure that you are not missing a non-PCO cause of androgen excess. You cannot use these tests to judge a response to therapy, by which I mean if you've started the patient on say, pills or spironolactone and you want to see whether the patient is getting better, you are not going to measure androgen levels. You are not going to measure your DHEAS, SHBG, and testosterone because the levels may be far different from what you visibly see. Your Perimin Galway will give you a better, accurate assessment of whether your anti-androgen therapies are working. Having said that, I feel it's also important to remember that we were taught something way back in our undergraduate and postgraduate years, and that's the imbalance between the hormones, FSH and LH, which actually leads to your androgen excess. This is our two-cell two-gonadotropin theory, which all of us have studied. This is our Pica cell, this is our granulosa cell, and we know that because in PCOS you have an overwhelming preponderance of Pica cells, you're going to have excess of androgen precursors, DHEA, androstenedione, testosterone, dihydrotestosterone, which are going to be circulating around and because your SSBG levels are low and excess of free testosterone, that gives rise to the entire cascade of androgen excess with the attendant complications, which will come to in just a couple of minutes. So, what is the impact of this androgen excess on the body? What happens is the female pattern is gradually converted into a male truncal and abdominal adiposity because of your androgen excess. And of course, along with your excess androgens, you're going to have not only abdominal obesity, but also insulin resistance, alteration in the hepatic and the reticular endothelial system functioning. South Asian PCOS is now recognized as a unique subset of PCOS. In fact, all the papers which you read in international journals, the guidelines, they all focus on Caucasian PCOS. And these patients behave very differently from our Indian or Asian Indian patients, so to speak. We have an excess of hirsutism with a lower SHBG. There is a higher free androgen index. There is greater amount of insulin resistance. We have resistant patients who don't easily respond to oral ovulagens when we come to fertility treatment. And even some patients you will find they are gonadotropin resistant. There is a much greater prevalence of acanthosis nigricans because the skin is completely different from Caucasian patients. You will find that the BMI is significantly higher, and at a lower BMI, we are sarcopenic, therefore, we have higher concentrations of central visceral adipose tissue. Now, this central visceral adipose tissue functions like an endocrine organ by itself. Because of this, patients have a more early onset of metabolic syndrome. If you remember in our undergraduate and postgraduate years, we were taught that unopposed estrogen for 20-25 years is finally what results in syndrome X or metabolic syndrome. Today, we are able to identify and diagnose metabolic syndrome even in young girls, girls who are adolescents. And that's because of the different ethnicity and the different subtype of PCOS that we see in Indian patients. As I said, these patients can be resistant to clomiphene, they can be resistant to letrozole, even sometimes even gonadotropins don't really work. When you finally make them ovulate, which is what we were taught all along, that ovulation is the problem, we are now encountering women who have altered endometrial receptivity and they have lower fertility as well. So that's something which we are now coming to terms with. It was not recognized 25, 30 years ago when we were students, but this is something which we have to deal with on a daily basis. I've just reproduced the lifestyle modification recommendations from Ishri. These have been covered in the previous talk, so I'm going to skip past these. Practical tips and the correct advice with periodic reinforcement is what is going to be beneficial for these patients. That is your and my role as the clinician and the counselor. It's very easy to say, go and run 10,000 steps. Very easy to say, do treadmill 3 times a week. Until we ourselves set an example to our patients and we have periodic reinforcement, that's not really going to work. And that's true for all of us. Nobody tells you and me to go and exercise 3 times a week. Otherwise, because you're 50 plus, you will drop dead one day because of a coronary. We need that advice. All of us need that periodic reinforcement. And trust me, even your patients need it as well. As far as diet recommendations are concerned, again, these have been covered. So I'm going to skip past these. Some amount of caloric restriction is beneficial. There are various different diets which are available, which have been shown to be of benefit in patients with PCOS. I'm not a dietitian. I'm not a nutritionist, so I'm not going to focus on that. What I will say is that a high protein diet seems to work well in combination with good amounts of judicious exercise, at least 120 to 150 minutes of moderate exercise per week. The most important $1 million question that we need to answer as clinicians is whether we can tackle the basic pathology at PCOS. PCOS today is something which is widely prevalent. Most of the medications that we prescribe are aimed at controlling the disease. There's no permanent cure, and that's something which you need to sit down with the patient, discuss. And at various different points in her reproductive career, she is going to need the appropriate advice, and she is going to need handholding from people like you. So let's start by talking about whether we can control this androgen excess. We would love to. Unfortunately, we are not able to, try as we might, because most of the medications that we prescribe only tackle the effect. They don't tackle the cause of PCOS. Maybe someday there will be a targeted gene therapy which will look at the reasons why this androgen excess occurs, and that will be able to actually cure PCOS at the root cause. Until then, all we can do is treat the effect and look at the various metabolic derangements, try to keep them in check. We know that there is altered insulin sensitivity. We also are aware that there are abnormalities of glucose metabolism, and all of these lead to the attendant complications, which over time lead to metabolic syndrome. What is now known, and that's something which is coming up over the past 7 to 8 years, is that the androgen excess influences certain molecules called as adipokines. And these adipokines function through the visceral abdominal fat or the central truncal obesity. They disturb your intracellular mechanisms and they cause a vicious cycle of obesity. So the only way to break that is to have regular exercise, caloric restriction, and insulin sensitizer. Which insulin sensitizers work well? We'll come to that in just a couple of minutes. So this visceral adipose tissue now functions like an independent endocrine organ. And there is a multitude, there's a long list actually of cytokines and adipokines which cause local chronic inflammation. And these reactive oxygen species are the ones which cause issues for patients in the long term. So you have a resistant insulin resistance, as I said earlier, and we are not able to tackle this because of the vicious cycle. We've already covered this earlier, so I'm going to skip past these slides and go to the actual treatment modalities that are now available to us. Since I practice infertility, I'll talk a little bit about fertility concerns. We've been taught that women with PCO have difficulty in ovulating. There are now various reasons why, even after they ovulate, the fertility is not all that great. One of those we touched upon briefly, and that's the altered endometrial receptivity. Now we are also being made aware that there is some defect in the signaling, whereby your follicular recruitment and selection itself is hampered, and that leads to what is called as programmed cell death or apoptosis, which occurs on a greater scale, and your follicles which are being generated, they themselves have poor oocyte quality. Now, this is something which we were not aware until a few years ago, and therefore it is probably necessary for us to have some mechanisms or some medications which will try and improve the oocyte quality in these patients. Another new concept which is coming up, and we rarely talk about it, is that women with PCOS are now experiencing premature ovarian insufficiency or premature ovarian failure, whichever term you want to use it. And the reason for that is because of multiple cycles of stimulation given by people like me who are fertility experts, the number of follicles or the good oocytes which are there are getting exhausted earlier and earlier. We were previously taught that women with PCO have lots of follicles. They will never have premature ovarian failure or premature menopause. We are now seeing women as young as 35 who are diagnosed PCO and they have very poor levels of AMH and mental follicle counts of 1 and 2. So premature menopause is also happening in these patients as well. And that's something which is very thought-provoking. A few simple pointers as to how we can treat these patients if they present with irregular cycles and they are less than 17 years of age. Just give cyclical withdrawal bleeds once every 3 to 4 months. A simple progesterone challenge test typically works well. With your lifestyle modification and insulin sensitizers, sometimes the disease can be kept in check, but some patients will require low dose OCs to be given cyclically, in addition to your myoinositol, dicarbonate, or metformin, whichever you prefer. Again, this has to be an informed choice which is made between the patient, her caregivers, and you. Typically, if she's an adolescent, then she's not going to be able to choose, and therefore that is where your expertise at counseling and taking the parents or the caregivers into confidence comes into play. About hyperandrogenism, we covered this a little while earlier, and Ashley also suggests that COCs are the first line, and you can use these in adolescents as well if your other basic treatments are not working. It's important here to realize that when you prescribe second line antiandrogens like your spironolactone, glutamide, and finasteride, you must counsel your patients that they should avoid conception because the second line anti-androgens are not something which we would recommend in first trimester of pregnancy. They are not allowed. Therefore, you should have efficient contraception also at the same time. This is part of the PhD algorithms which we did a few years back, and I've just reproduced it here for your knowledge. Another concept which is important and which we must remember is that there is defective signaling intracellularly in these patients who have PCOS. Your second messenger is not working well. And the second messenger in your glucose metabolism is something called as PI3 kinase, and your GLUT4 is what is not functioning well. So you need something which works at an intracellular level. Remember metformin, which we've used for 50 years, works on the insulin receptor, which is a cell membrane receptor. If we had something which worked intracellularly, that would be the perfect way to go. And we do have something that works intracellularly, that's called myoinositol and bicarbonate. So are there any simple protocols that you and I can use in clinical practice? These are the TOG algorithms which Foxy did along with Science Integra a few years ago. Again, these are public domain. These are easily available. They're there on the Foxy website as well. And in case you can't find them, please feel free to write to me. I'll be happy to share them with you. So they look at different ways of treating both patients who are presenting with infertility, patients who are presenting with obesity and high BMI, and patients who need treatment for hirsutism and acne, which can be quite disturbing. There are some new recent developments, and this is actually the guideline development group which worked on the guidelines for acanthosis nigricans. We were led by Dr. Guru Shah, a past president of FOXI, current president of the PCOS Society of India. You'll see me somewhere in the background. We had a host of other organizations also contributing to this, including ICMR, the Mumbai Society, the Endocrine Society of India, and also the Dermatology Society. So this guideline is being published in the Journal of Association Physicians of India, JAPI, very soon. And please look forward to it. This is adapted from the most recent updated evidence available worldwide, including international guidelines on acanthosis nigricans, which, if you remember, we were always taught is one of the pathognomonic factors to diagnose PCOS. As far as morbid obesity is concerned, more and more patients are presenting with obesity, which is refractory to the regular treatment. Should we offer these patients treatments like bariatric surgery? Are there any other medical options that are available? Are they actually viable in our Indian population? That's the subject of a new guideline on obesity, which is under the auspices of ISAR. We are working on it. Hopefully, in a month or two, we will be able to publish those as well. We did these protocols for practice in 2019 when we were led by our toxic president, Dr. Melita Palshetkar. This is a picture from the managing committee meeting. We did a lot of important things there, and we put together the most recent updated available evidence, and we put it together in the shape of a checklist. We also did a 7-step counseling guide in association with an international aware group. Again, for reasons of paucity of time, I'm going to skip past these slides. These are again available on the POPSI website, and you will be able to see these very easily, download them from the website. The new evidence regarding insulin sensitizers is the last part of the talk, and I'd like to take a couple of minutes to remind you that we have agents which are functioning intracellularly at a microcellular level. And these are called inositols. Since I come from infertility, we are aware that those patients where the follicular fluid is deficient in inositols, usually there is poorer oocyte quality and there is less chances of fertilization and implantation of the embryos created from those oocytes. If you prescribe minoxidil and dichloroinositol, they are supposed to lead to better oocyte quality. There are plenty of papers for this. They've done this study by retrieving follicular fluid, subjecting it to chemical acid, and of course, you can see that when supplementation has occurred, you get better quality embryos, which leads to better clinical pregnancy rates and live birth rates. Prescription of these newer insulin sensitizers is being shown to reduce the duration of stimulation, the amount of gonadotrophins which are consumed, lesser amperage of FSH, improve pregnancy rates, and of course, better insight and embryo quality. Again, the new recommendations by ESHRE now no longer refer to inositols as experimental. They say that these can be considered and they have lesser side effects as compared to metformin, which is known to cause GI issues, but that is something which is a conversation between the patient and the clinician, and that has to be offered to the patient. Document that choice and then go ahead. N-acetylcysteine is something which is now coming more and more into prominence because it is supposed to be a good antioxidant. Remember, we said just 5 minutes ago that in women with PCOS, there is greater programmed cell death or apoptosis. N-acetylcysteine has anti-apoptotic activity and therefore gives you better follicular recruitment and better oocyte quality. Also has anti-cytokine effect. In fact, there are small papers today which show that it improves oocyte and embryo quality, gives you better clinical pregnancy rates. This is one paper from Taiwan, which says that women treated with N-acetylcysteine have better clinical pregnancy rates after ART. I'm very happy to announce that my most recent book on drugs in OBGYN and reproductive endocrinology was just released a couple of days ago. And this is actually here as a slide in this talk, not just for advertising the book, because I actually wrote a chapter on a new insulin sensitizer, which is now available to us, and that's called berberine. Berberine reduces the insulin resistance, it alleviates your abnormal lipid metabolism, decreases chronic inflammation, improves your reactive oxygen species and oxidative stress, reduces your anti-androgen levels, and therefore it improves fertility outcomes. There are plenty of small papers. There is a meta-analysis which is there in my chapter. If you go back and read the book, you'll find that women who have been prescribed berberine have much better waist circumference significantly better improvements in lipid parameters as compared to metformin, which is considered the reference drug. Also, the waist-hip ratio is significantly better in patients treated with berberine when compared to metformin. Your HOMA-IR insulin sensitivity, all of these are much better in patients who have PCOS and who are treated with berberine. We as yet don't have extensive studies and data from Indian patients, but I would appeal to all of you to please use this new agent in your clinical practice. Try it out, maybe put your data together, publish it, and maybe this will be something which will be one of the newer alternatives that we can offer our patients. Just like 10 years ago, when Mayo and decarolus first came in, they were met with a lot of skepticism. Every new agent that comes in and says, okay, I'm the best, is going to be met with skepticism. The proof of the pudding is always in the eating. Unless we try it in our patients and we find improvement, we are not going to be able to suggest that this is something which works very well in our Indian patients as well. This is another study with 150 patients. Again, they found that berberine significantly affects the HOMA-IR, decreases fasting glucose, decreases free androgen index, total testosterone within a short period of just 12 weeks. So pre-treatment for 2 or 3 months before you run your index or your treatment cycle seems to be the order of the day. And there are patients who have been undergoing ART and they found that the FSH consumption is lower, fertilization rates are equivalent, and clinical pregnancy rates and live birth rates are significantly better with lower side effects when compared to metformin. So I'll close, ladies and gentlemen, with a few simple, important take-home messages at the end of the talk. PCOS is now the new hidden pandemic. The most common complaints that women present with today are not infertility, which was the case 20 years ago. More and more patients are coming forward in the adolescent age group with acne and hirsutism. Therefore, you need to have a multi-pronged, multidisciplinary approach. Lifestyle and exercise is something which we all advise, but that doesn't necessarily translate into action by the patients. We need to set an example for our patients, continue reinforcement. Remember that insulin sensitizers and exercise are the mainstay of treatment besides the other drug therapy that we offer our patients. Pleasure in our jobs puts perfection in the work. And if we guide our patients in the right way at the right time, utilizing the correct medications, I'm sure PCOS is something which we no longer need to fear because we have so many different things today in our armamentarium. Thank you very much for a patient hearing. I'm happy to take any questions.
Before
thank
the
you.
chairperson gives her concluding remark, Dr. Tarini, I would like to put one or two words. Fantastic presentation as usual, Dr. Pratik Tambe. The semaglutide we are using nowadays, but we stop it and again the patient gains weight and also it is costly also. There is new drug in the like berberine. Berberine is quite old drug, I will say. It was vanished in between through the market and again reappeared. There is another one new drug has been introduced recently and it is far, far more better than semaglutide. That is what, so we are awaiting the results also. So I'm really thankful. I thought I should attend your talk because always there is some take-home message definitely hidden somewhere in your talks and academically oriented. In your updates always you are giving us and we are really, you enthrall the audience like today also we were very happy to attend it. Thank you. Over to you, Dr. Tarini, and thank you, Dr. Pratik Tambe, for giving me the opportunity for
Thank
this
you.
TOG.
Thank you so much.
Thank you, dear Varsha, for giving the platform to speak something about the Dr. Pratik. I'm really, it's always pleasure to listen. Pratik, as you said, we always get some new messages and something very new about the topic. So that's why in my peak hours, I agreed tentatively, yes, I will attend. Because these are the in the art place very, very peak hours for the practice. So I could know one thing more new. Like I used to think there is only the culprit for the increased androgen is the peripheral insulin resistance and fat cell. And third thing he said, the visceral obesity, visceral fat is again act like a organ to produce the ultrasound. So I just think so many things I could learn more from both the topics are very, very good with the updated lifestyle and everything. So I think how to, help public. I used to go in the school for this lecture for the awareness, because our purpose is to know, to update only, to deal and to give the better treatment, rather best treatment to our adolescent reproductive age group of patients. So with the awareness I'm doing already, so I believe everybody awareness is very important in this factor. Second thing, what about your experience for the intermittent fasting in reducing the fat? Have you any experience for that? Because I think intermittent fasting is decreases the glycogen level, because it use the stored fat for the energy, and also decreases the insulin level. It is balance the hyperinsulinemia, and also balance the hormones ghrelin and the leptin levels. So somehow it balance the fat and try to rejuvenate your mental health and physical health. So that I wanted the experience from both of you, from Varsha and Dr. Pratik Tambe. But it more like the follicle numbers you told. So with the 3D and 4D like probe I'm using, so many times we get at least more than 10, 12, 14. I try to like focus on the peripherally arranged only. Even then, many times we confuse with the report of the like from the other ultrasonologists. So how to tackle with that? That is my question. Though you had told we should see the follicle number and per ovary and follicle per cross section. That is very important. But how to, educate that the ultrasonologist? Everybody is getting from the machine, maybe the very simple machine, many the BMS are doing, technician are doing under the cover of the educated and qualified person. So I don't know what to do. So every person is being treated, every girl is being tortured by treatment of this.
So the simple answer
PCO.
to
Yeah,
that
One
very
girl
well
is
is not getting. Yeah.
the simple answer to that, ma'am, is that if you use a transvaginal probe of 8 megahertz in an adult, as we said, you cannot use this in an adolescent in India. It's not
But
something
for
that they
reproductive
do.
life, the patient is married
Exactly.
in
I'm
early age,
coming to
and
that.
that we can
I'm
use.
coming.
Yeah.
Yes, I'm coming. So the cutoff today is 20 follicle number per ovary when you use an 8
20.
megahertz
Yeah.
probe. And this
With
is
which
something
machine?
which is
Sorry,
easily
which machine?
achievable.
Is a
Any machine you can use, but it has to be
basic
an 8
machine?
megahertz probe.
Okay. And it should
And
be
if you,
peripherally arranged. That is the
yes,
important.
and you will easily get 20 because with the newer probes that we now have compared to 20 years back when we had 3.5 megahertz का कुछ दिखता नहीं था, you can easily get 20 follicles per
Yeah.
ovary in patients who genuinely have PCOS. Because now with these probes, you can pick up even 4 and 5 millimeter follicles, which once upon a time we could not see. So that criterion is very easily fulfilled. At the same time, as you rightly pointed out, when you look at peripherally arranged follicles, you can exclude patients who have multicystic ovaries or physiological excess follicles, which are seen during the time of adolescence. At the same time, you will be able to get a more accurate number because on transabdominal scan, you're not going to be able to see these. I think that takes care of a lot of operator error and subjectivity that is there as part of the diagnostic process.
Yes, so
So
as
I think
Pratik
more,
has
one thing more.
told, ASRM has given the guidelines of 20 in each follicle. That is very, very diagnostic, not 10 or 12 or 15, 20 and above. That is diagnostic of PCOS. So it is very easy now. And another, I like your question about intermittent fasting. It is really, really helpful according to physiological
Can I just say one
giving
sentence? I'm sorry to interrupt.
presentation of,
Just one
yeah.
sentence. Intermittent fasting is something which is new for Western civilization. In India, we've been practicing intermittent fasting for centuries together because all of our women fast on various religious functions, half the month they are fasting. So that is intermittent fasting in clinical practice, in actual practice. I'm sorry I interrupted. Please go ahead.
Nowadays, modern India is like westernized. They are eating, the eating habits have changed. So definitely, it does have the value because it really the sugar levels, intermittent fasting will sugar giving inflammation. So that is cut off with the intermittent fasting. Definitely, the person feels energetic. The brain works well. Is more energetic. Depression. So all the side effects of PCOS are really vanishing with the intermittent fasting. So what I tell my patients, कुछ नहीं होता है ना, just 2 बार खाना खाओ बस, बाकी बीच में दाना भी नहीं खाने का. So that definitely helps and it becomes a simpler version for them as a treatment and prevention of PCOS. So you really brought very good question, Dr. Tarini. I congratulate you for that. Intermittent fasting is here to stay and it is the answer for PCOS or metabolic all syndromes, because I have seen myself also, even my brother who was advised taking insulin, he is off medication and the weight also balance occurs and it is physiological and it is easily achievable also.
So thank you,
So there
Dr.
are,
Barsha, Dr. Pratik. One thing more, like from the Foxy, how can we do the extensive advocacy from the take the help from the government for the playgrounds and for the this fast preserved food that is literally harming the generation. Yes, sir, with the full of the salt and so many preservatives. So how can we deal? That is the main culprit. If you go in the market, it's a full of the like a counter of the food counters. Everybody is eating
घर का
pizza
खाना खाने
and
का,
all
बस घर
pizza
का खाना
food.
खाने का बस.
So what how to deal that? And
so I think
we
all of
many
us, we need to
eh?
remember that as doctors and clinicians, it is also our job to educate our patients.
Yeah,
It is important for us to go out in the community, go to schools and colleges, maybe once
I go
or
too
twice a
much
year.
public
Try
forum.
and Absolutely. Try and educate these young people about what is the best practice as far as diet, nutrition, exercise, etc. is concerned. But
But
then that is something which you can do maybe once or twice in a year in one individual school or college. Around the year, remaining 48, 49 weeks, the benefit of whatever we have said is not going to be there. So that periodic reinforcement is essential, for which there has to be a mass media campaign which is going on around the year. Whether we are
that's
able
why
to do it in our
Another thing,
individual
Pratik, I would
capacity,
like to have that book that you have recently published with Nandita Palshetkar, and
it's
that
there
is
on
our
Amazon,
take-home
madam.
message.
It's there on Amazon.
congratulations,
Okay,
Dr.
thank you.
Pradeep. I
Thank
already
you.
congratulated. I was there. So one thing, that's why I'm saying the extensive advocacy at the government level. Because as a person, I can help. One drop is literally matter in the ocean. But we need extensive this advocacy for the playground and strict hours in the school should be for the outdoor activity. So that's going to help us for the
I would agree.
argument.
I would
Yeah.
agree. Dr. Jyoti
And
is there
what about the
silently
art?
listening to
I'm
us.
waiting for the artificial intelligence. It can do if it can help us. Artificial intelligence in the
Hopefully,
long
AI
run.
will be able to guide our youngsters better in future, much better than we can whenever we
Yeah.
talk to them. Dr. Jyoti, there's a question from the audience, and I'm coming to the audience Q&A part of the program. There is a lot of discussion on coenzyme Q10 in PCOS. Now, neither I nor you have talked about it, so I felt maybe we can address this. Do you think it improves metabolic and endocrine issues in women with PCOS?
Yes, CoQ has been off late, been advocated for all these patients. But if nothing else, at least the energy levels in these patients, they always come back and say that the energy level has improved.
I agree. I think this is something which probably all of us would benefit from taking CoQ, not only patients who have PCOS, because
Yeah,
it's a mitochondrial energizer.
yes.
There is a question regarding the protocol for treatment of PCOS and infertility. I think that's the subject of an entire program by itself, so we'll do that on another day. What is the difference between lean and obese PCOS? Jyoti, you want to take that?
Lean and obese PCOS, you will see both the spectrums in your clinic, even in adolescent PCOS, even in infertility population. So it is the lean PCOS and obese PCOS. Of course, the lifestyle management and weight reduction will be the first forte to help achieve all the other goals. But whereas lean PCOS, though they look very easy to deal with, but sometimes even they feel you get a lot of resistant lean PCOS. So with them, it is more difficult at times to deal with stimulations and infertility practice. But in adolescents, of course, the metabolic syndrome and other things can be managed much easier compared to the obese PCOS.
Thank you, ma'am. And one last question we have, and that is, other than metformin, is there any other insulin sensitizer which is recommended for the treatment of PCOS? So I think I touched upon all of them, what is currently available in our basket, what is being proven to be scientifically effective in our patients is myo and
I think you covered it
dipyroinositol.
all.
We've seen N-acetylcysteine. We've seen melatonin also, though melatonin itself is not
Yes.
supposed to be an insulin sensitizer. And the most recent new kid on the block is berberine, for which we have a lot of hopes. Hopefully, that will transform our practice
Melatonin and
very.
vitamin D3 in PCOS has been recommended
Yes, yes,
because
absolutely.
melatonin works directly at the oocyte level.
Yes, absolutely. So I'd welcome any closing
Thank
remarks
you,
from our
And all the
organizers.
chairperson.
Thank you
DHEA
so much.
celebrations are now using melatonin as a combination where the poor responders too.
Yes, I agree. I agree. Dr.
For
Vacha
each and
Baste and
every
Dr.
patient, I
Taran.
use melatonin.
Dr.
Pardon?
Jyoti,
Yeah.
Dr. Jyoti. So
Yes,
after a
ma'am.
long, we could see you, and it was good presentation. Good,
I'm happy
good
both the
presentation.
chairperson and
Very
the
Thank
good.
you.
secretary of Delhi
Thank
sir
you,
are there in
Dr.
my program.
Dr. Yeah.
Sorry,
Thank you,
sorry,
Dr.
Dr. Pratik.
Jyoti, Dr. Tarini, and Dr. Pratik. Thank you
Thank
so
you so
much.
much.
Thank you. So I'm very happy to announce that we have over 1,000 viewers who are logged in nationwide.
Wow.
If there are no further
Wow.
comments, then I'll present the official and formal vote of
I
thanks.
think Pratik, your name was enough to pull 1,000. You can
नहीं
even
मैडम, वो
pull
दिल्ली
8,000
हिसार
too.
का स्ट्रेंथ है, बस
नहीं नहीं
ज्योति के
आपका है
नाम
वो
से आ गए.
बॉम्बे से बैठ के चलाते हैं वो तो आप.
चलो शब्बा खैर धन्यवाद राधे
Thank you so
राधे
much,
So I'll
Pratik.
just
goodbye
present
thank you so
the
much
formal vote of thanks. I'd like to express my gratitude to Science Integra and the TOG Experience Series, which I said we started off way back in the pandemic. My gratitude to Glisten, our educational partners. They are the makers of Beritol, which includes berberine, also IV-Mag and injection I3, which is magnesium sulfate and iron isomaltoside, respectively. Two fantastic chairpersons, Dr. Varsha Baste and Dr. Tarini Taneja. Thank you so much for being with us despite your busy schedules. Hats off to Jyoti for her amazing talk on adolescent PCOS, and I'm not going to pat myself on the back for
Of
another
course
next
you
talk.
should.
Congratulations
But
to
I
you,
hope it was
Dr. Pratik, for
beneficial to
excellent,
everybody. And
congratulations both the fantastic speakers really
excellent
we
talk.
really loved it attending everything thank you
So many new,
thank you.
bye
Dr.
bye for
Pratik,
now
just tell me about the this you said the berberine has come. So
Yes,
is it available?
it's available widely, ma'am,
Is
in all
is
major
it safe?
metros.
It is
It's
safe.
very safe, it's effective, it's actually based on a herbal preparation, and it has much lesser side effects as compared to metformin. Of course, as I said, we don't have much Indian data, and that is why I appeal to the audience to start using it to publish that data so that we have valid, good Indian data that we can show the next time we talk about this one.
So if it is available, I'll try to on my patient also
Definitely.
with taking the consent. We are
Yes,
trying on you. So what is
absolutely.
the dose? Can you highlight to me
I will speak to
and
you
how?
about it a little later, ma'am.
Okay,
Okay,
okay.
so I think we'll call this program to a close. Until next time, goodbye, God bless. Thank you everybody for joining in, and I hope
Thank you,
you
Pratik,
gained
for the
some practice
invitation.
points from the program.